Hi, everybody. Happy Baby Friday. This is Betty Hovey with Compliant Healthcare Solutions. And today, the topic that I will be covering is prolonged services, the new 99417 code that was added, and CMS with their G code, the G2212, and kind of comparing the two to see where the kind of draw sand in the line came when CMS felt that they needed to make a HCPCS code because they didn't agree with the AMA and how they had interpreted their own guideline for the new CPT code 99417. So I'll give a few minutes for other people to come in. And as you come in, please give a little comment, a little shout out. So I see Faraz. Hi, Faraz. How are you doing? I hope you're having a good Baby Friday. And then we will, I have a little PowerPoint presentation that I have made on this subject to kind of keep me on track as we go through things, and a few examples. And then I did receive a couple questions from people, so I will answer those questions and then answer any other questions that people may have for me. If you have questions, you can just put them in the comments. I also do have a little present, so to speak, for everybody. As I get to the end of the presentation, I will show on the screen how you can get that. I made a chart for the AMA and CMS differences in the prolonged service table. So I made a couple tables that you can just download. It's two sheets, one for new patients, one for established patients, and have it as a reference, as a quick reference if you're trying to figure out prolonged services times how many units of the codes you want to use, and those types of things. So let me go ahead and I will pull up my screen here to show you. All right. So let me put myself a little bit, put myself a little bit smaller here. There we go. All right, so as I said, this is going to deal with the prolonged service codes and the issue that we're having with CMS versus CPT on the difference in the codes that they're using for prolonged service. Because if you read the descriptors for the codes, I have them one on top of the other in one of the slides, you'll see that they're identical. Oh, hi, Mary. So good to see you too. I'm glad you could join me today. Hi, Kim. Hope you're doing well. All right. So here I thought we would just start with a refresher of just putting up what the times are for each of the levels for E&M codes. So we have the new patients first here from 99202 to 205. And you see over in the last column here, we have the times, the ranges 15 to 29 for a 2, 30 to 44 for a 3, 45 to 59 for a 4, and 60 to 74 for a 5. Now, in the parents next to the codes, I also put what the old time requirements were from last year and the previous years, because there is a kind of sticking point that I find with physicians who are continuing to code by time when it's appropriate, but aren't remembering, the new ranges correctly, and it's causing them to overcode certain services because they are using old time with the new codes. So I'll show that in a second. And then here are the established patient codes. So we have again, the 99211 this time, because of course they did not delete that code. They just deleted the 99201 because they said they wanted to leave the 99211 in. And when I say they, I mean the AMA when they made the CPT codes and revised the CPT codes, because they still need the 99211 for the nurse visit type of services that are done. So we do still retain that code, but you'll see that there's no applicable time range or anything like that with this code, because CPT states that, it doesn't fall under the same principles as the other codes in the established patient section. So then we have a 99212, which is now 10 to 19 minutes. A 3 is 20 to 29 minutes. A 4 is 30 to 39, and a 5 is 40 to 54. Oh, hi, Sandra. I hope you're doing well. And then once again, over to the side, I put what the old time requirements were when they were static times. And I'll remind us of that again when we get to start to looking at some examples. So when we want to code by time, of course, the criteria to code by time according to the updated and revised CPT guidelines is that in the old days, we had to be, just the face-to-face, and more than half of it had to be counseling, but now in 2021, it's all the time we spend on a particular day for that patient's care, and it may be cumulative over the day. And of course, as always, our documentation is key. That is the key factor that we are going to look for from an auditor standpoint to support the code when it's done by time. And from a payor standpoint, if they're requesting your records, they're going to want to see all of the things that were done to support coding by time, and that it makes sense that it would take that much time. So CPT also put out guidelines to state what is going to be counted when you code by time. So you can count your preparation to see patients, such as reviewing hospital records that have come over, reviewing labs, reviewing x-rays and images, and maybe other letters from providers or providers' notes on the patient, obtaining and reviewing the history, doing your exam, counseling and educating the patient's family or caregiver, ordering meds, referring and communicating with outside healthcare professionals, documenting clinical information, independent interpretation of results, as long as you're not separately reporting them. And those kind of issues are going to become important from a documentation standpoint, to make sure that when the physician or other provider is documenting those things, that if they're reviewing an x-ray, so let's say for an example, the physician states or other provider states in the documentation that I spent 5 minutes reviewing the x-ray films that are not separately reported by me or from an external source, to make sure that it's clear that it is not a service that your practice is already billed for. Because if you were paid for that x-ray, taking that x-ray in full as a global service, part of that service is, looking at the results, looking at it and giving results. So if you were paid in full for that service as a global service, you should not also be counting that time as time towards your E&M service, because that's, of course, double dipping. And then care coordination. And now this is encompassing of the whole entire day. So if the physician or other provider looks at some stuff prior to the patient coming in, then spends time with the patient on the visit, and then let's say talks to their primary care physician after the visit, all in the same day, all of that time adds together as the cumulative time. You just they just need to make sure they're documenting all of that information in the chart. So if you use electronic medical records, you may want to have templates that have areas for the physicians or other providers to be able to kind of like check the box and say, pre-service, and then they can write all the stuff they did then. And then for the service, you'll have your E&M record for that day. And then post-service, have another area to where they can check and say, at 2:00, the patient's visit was at 9, at 2:00, this specialist called your office and your physician talked to them for a while. So they want to add it in so that they can get all of those services combined together to add up to what the service is going to be for the patient, which of course, when you look at it that way, all of those things that they do, depending on your specialty, easily could lean into prolonged services for some of these patients. Some good specialty examples where this would happen would be hematology oncology. When you're talking to cancer patients and you're going through treatment plans and what their prognosis prognoses are and things like that. Any kind of pediatric subspecialties, PD cards. If you have a baby that you're going to have to do heart surgery on, you probably will have a nervous set of parents that will have a whole bunch of questions and will want to know in detail all of the things that are going to go on for the upcoming surgery and all the coordination that's going to be done and what's going to need to be done for the baby after the surgery and things like that. So you can see where cardiology for adults also, for the same kind of issues, we have where prolonged services could come into play. General surgery, if they're doing mastectomies, you could have, I had one physician, he was a general surgeon, and he used to do mastectomies. And when he'd do a mastectomy, he would allow the patient to bring her family members, her husband, or anybody she wanted in to the visit so that he could discuss everything and answer everybody's questions. And so sometimes, as you can imagine, those would get to be really long. And he had models and different things that he would bring out and show different things. So he could show to them different kind of repairs and flaps and reconstructions that could be done too, along with the surgery or after the surgery. So sometimes they were in there for quite a long time. So make sure now that with the change that they've done to the E&M office visits for this year, that documentation is complete for all of those things, and you're capturing all of that and documenting it so that you can add it all up at the end of the day, and see where you shake out and make sure you're getting paid appropriately for your physicians and other providers' time. So what doesn't count is if things that are done by clinical staff, just like before, because clinical staff, is being paid for from the budget for the practice. It's not, the physician specific service. Time spent on separately reportable services, as I said before, like the EKGs, the x-rays, things that you're billing and getting paid for separately, you can't count in the prolonged service time or in the coding by time for just the basic level for the E&M. If minor procedures are separately done, you have to make sure that you carve out that time. And again, in the documentation, it's also important to do that. So I put a little example up here that says the patient's performing, the patient presents for a 20-minute visit regarding his hypertension. Also, he has prior therapy of 2 AKs during the visit, and that took 6 minutes to do the cryotherapy. So if the visit was being leveled by time, the 6 minutes for the cryo would need to be deducted from the 20 minutes from the visit. So you could document that in different ways, depending on how the physician likes to document. So the note could either say a total of 20 minutes was spent with the patient today, and 6 minutes of that was spent doing the minor procedure. So then they would just take the 6 minus the 20 and get 14, or it could be documented as a total of 14 minutes was spent in patient care today, not counting the time for the minor procedure. So then that would be clear to a payor that it doesn't matter how long it took for the AKs to be done because they're being paid for separately. But for the visit itself, I have 14 minutes, and that's what I need to get paid on. So the proper way in that case would be a 99212 with a modifier 25, because the hypertension is significantly and separately identifiable from the AK's cryosurgery, and then 17,000 and 17,003. So, always make sure that you're utilizing the correct modifiers on things and appending them so that the claims are going to go in clean and we're going to get paid. So the documentation requirements, I just put some examples up through here also. For documentation, of course, needs to be clear and clearly indicate the nature of the services performed. So we can't see notes that just say, I spent an hour on the phone after the appointment. Doing what? An hour is a pretty long time. So a payor is going to want some meat in there, in the paragraph, in the descriptor for the medical record of what exactly was done. Who did they speak to? What were they talking about? To ensure that it was patient medical treatment care related. Also, the documentation needs to indicate the amount of time for those separately reportable services, that it was not included in the total time, which was one of the things that I just gave an example of a minute ago. So if you're reporting both an E&M by time and a minor procedure, documenting total patient care time of 30 minutes would be sufficient for the reasons that, I just spoke about a couple minutes ago. And also, documentation must support medical necessity of the time spent on the patient encounter. This is where our ICD-10 codes come into play. And with ICD-10, we have so many more coding choices now, and they, continue to add more and more. But we went from 9,000 codes to 60,000 codes, and so it's taken a while for practices to kind of catch up with the specificity and with using all these codes. So I still continue on my audits today to see where comorbid conditions are not being coded for. And those comorbid conditions could definitely help to explain why a visit would take longer than another visit. If you have a patient, I had one where the patient was having Mohs surgery, and the patient had was a hemophiliac, and so they were a bleeder, and that was not diagnosed. The diagnosis code for that was not on the claim form. And when the surgeon was explaining, the procedure and going through that and the different kind of things with the fact that they had von Willebrand's disease, that's the type of hemophilia they had. The fact that they had hemophilia came into the discussion and took a little bit longer for them to, describe and connect with the patient on those kinds of issues, at the different precautions they would have to take and things like that. And so spending extra time with the patient for an issue like that makes sense. But if the ICD-10 code for von Willebrand's disease isn't picked up, then it kind of loses that power in adding to the support of that E&M code, or that level of E&M code. So as it goes through, if a payor may question a claim that doesn't have it and is at a level 4 or 5, let's say, then a claim that does contain that information at that level 4 or 5, that makes more sense. So if they're looking at things to try to take and look at for record purposes, okay, which record am I going to ask for? They're going to ask for the record that doesn't have that additional ICD-10 code on it. So you have to make sure that all of those comorbid conditions that are adding into the complexity for treatment, because that adds into time for treatment, that those things are getting reported. So keep an eye on your ICD-10 CM codes. They're still very, very, very important to make sure that we're supporting our services. So now with prolonged services themselves, the codes, we added this new 99417 code. So that's going to be used with the office visit E&Ms only, though. So when they made the split and made the new revisions, they were only to the office visits. So this new prolonged service code is only for use with those office visits. And if y'all have been watching the AMA, they also have put out notice about the changes for the other E&M codes in the section, and look for those in 2023, they're saying right now. So in probably in this year's Federal Register and the proposed rules, we'll probably see some information on them for 2022, where like last year when they were coming out with the new ones in 2019, 2020, they kind of were mentioning it because they were getting ready for it. And the AMA had a meeting and put out some information earlier this year on it, but it was kind of vague. they are looking at deleting certain codes and making some changes, but they haven't been very specific yet. But when they get more specific and we see more information out about it, I'll be sure to be broadcasting about it and probably writing about it in BC Advantage and other magazines. So the other things with these, the 99417, they did lessen the time. They lessened it down to 15-minute increments where the physician would be getting that extra payment with the extra 99417 code for the extra time. So also they have to have the full 15 minutes though. So this isn't one of the codes where once you get to more than half the time, you can go ahead and report the service. So this isn't like, since it's 15 minutes, if you do 8 minutes, you can go ahead and code it. It has to be a full 15 minutes for each unit. So if they do 16 or 17 minutes over, you would get 1 unit, but not 2, even though you were 2 minutes into the next. So if they did 29 minutes, you would only still get 1 unit. You couldn't report that second unit until they hit the 30-minute mark. So that's also important when we're talking to the physicians and other providers, that we want to make sure that they don't do approximately 25 minutes, approximately 15 minutes, about 15 minutes could be 14, about 15 minutes could be 16. So if it's 14, they don't get the 99417. If it's 16 or if it's 15, they get it. So try to work with them on saying this much. Give me a specific time. Please don't approximate, don't guesstimate, don't say around, about, anything like that that makes it unclear about what the actual time was. Hi, Rose. Thank you very much for the comment about the info. I'm glad you're finding it useful. All right, so let's take a look at a couple little checks here, and then we'll move on to looking at the comparisons with CMS. So if we have on February 2nd, a physician spending 15 minutes looking over new patients' medical records, 25 minutes face-to-face time on the actual visit, and another 8 minutes post-visit documenting and ordering tests, what level of service would this be for a new patient office visit? So I'll give you guys just a couple seconds to look that over. Let me see if, let me go back. I should have put another. So what did I say? Was it a new patient office visit? I should have added this in again. Okay. So we have 15 minutes, 25 minutes face-to-face, and 8 minutes post-visit. So we add that all together. So we have 25, 35, 40. We have 48-minute visit. So that would be a 99204. Then we have on number 2, the nurse's time with the patient can be added to the physician time for an office visit when coding by time starting January 1, 2021. So with the things that I went through on what can and can't be counted, is that a true statement or a false statement? And I know they tell me there's a little delay here from my time into getting into the LinkedIn. So I'll get a second in case I have any brave soul that wants to give me a true or false. Mary says false. That's correct. It is false. Remember that the clinical staff time can't be counted in the prolonged services time when you're counting it up. All right. So what time does not count in 2021 if you're choosing a code by time? So this is another of what you're not going to do. So if you look at these, it may be more than one. So A, preparing to see the patient, does that count? B, a lab performed during the visit, would that count? C, performing an exam, and D, counseling the patient during a visit. So what time doesn't count out of that? Hi, Julie. Thank you. Mary, again, we got a B. Anybody else want to stick in there to see if I've got somebody else that agrees with Mary? You guys agree that it's B? Kim says C. Oh, it would be B because they would be separately reporting the lab service, so that lab service wouldn't be counted into the time. And one more, what will the new criteria be for reporting prolonged services with the office visit codes? Now here you're going to choose all that apply. So they can only be added to 99204 and 99215, or sorry, 99205 and 99215. They can be used with any office visit E&M code. They must have at least 30 minutes of prolonged services documented, or they must have at least 15 minutes of prolonged services documented. So 2 out of those 4 things are true. So which 2 would y'all pick as being the things that we do want to do with the new prolonged service codes? I've got an A and a D. Anybody else? I've got a B and a D. So it looks like people are pretty strong on the D there because that's written into the code, right? So that one's kind of the easier piece that yes, they are for the 15 minutes. You don't need 30 minutes anymore. So D is one of our choices. That's correct. And if you remember the other one with the new prolonged service code 99417, they can only be added to the level 5, to the highest level services, because if you're lower than that, let's say you're at a level 3 and your time goes over, well, then you just move up to the next code, right? Does that make sense? So instead of a 3, you would go up to the 4, or 4, you go up to the 5. But once you get to the 5, you've got nowhere else to go. So that's why we brought the prolonged service codes in. All right, so now some people didn't realize this, and it took me a minute when I was writing my stuff up for prolonged service. I was like, wow, there are actually now 4 different subsets for prolonged services. So if you use the other ones or don't use the other ones, you might want to go back and check the CPT code book and look over the guidelines here where the prolonged services are, because now we have prolonged services with direct patient contact. That is not for the office visits. That would be our 99354 to 99357. We also have prolonged services without direct patient contact, the 99358 and 99359. And then the prolonged clinical staff services with physician or other qualified healthcare professional supervision, 99415 and 16. And then our new 99417 that is just to be used with the office visits. Yes, Rose, I know it makes your eyes roll, doesn't it? So there's a lot of different prolonged service codes that can be used. I also think a misuse set for prolonged service codes are the 99358 and the 99359 for the without direct patient contact. You know, those services, if let's say you have a new patient coming in and they are, you get the whole stack of medical records for them a week before they come in. Now, 2 days before they come in, the physician starts to look at them and go through them and spends a half an hour, 45 minutes looking through these records, but it's 2 days prior to the service. So we can't use it on the date of service to add into the prolonged service stuff going on then, that's when you want to use the 99358 and 99359. Or you have an established patient that comes to see you and brings a whole bunch of stuff with them from, when they were on vacation, they had some kind of accident, and, so now they're bringing all this stuff to you to look at. And you don't want to sit there and go through it while you're having your office visit with them. You say, I'll go through it later. Let's say it's 2 or 3 days later before you can get to it. Well, once again, that would be a time when you could use the 99358 and 99359. So check those codes out and make sure that there's not circumstances where maybe you should be using those and getting reimbursed for the physician time for it. Mary had a nice comment. She says, and we wonder why providers get frustrated. So it's a lot of stuff, and that's why they need good coding staff that understand what these guidelines and what the rules and these different services and different abilities that the physicians and other providers have to be getting reimbursed for these services. There's nothing worse than working and working and working and then seeing no compensation for it, or thinking you're getting no compensation for it. Just think about how much of a hero you could be going in and say, all that time you're spending doing that, there's codes that we could get you paid for those. And so it's things like that that just holds and makes your value to a practice shine even more. So be looking for different things like this that are separately reimbursable for our physician and other providers' extra work, or just basic work that they're doing for patient care that they need to be getting reimbursed for. All right, now I made a slide here that just shows the breakdown of the different prolonged services. And notice, going back to that point I just made about the 99358 and 59. If you'll notice with these codes, all of the prolonged service codes, starting with the 99354, 99356, 99415, all the other ones are add-on codes. But 99358, as you will see, is not an add-on code. It's a standalone code. So in that situation where you have the patient come in and bring all that stuff, and your doctor doesn't get to look at it until a couple days after, well, the E&M for that service is already gone. Well, that's okay. 99358 is a standalone code. You can report that code by itself 3 days after the service, and it's valid and you can get paid for it. You don't have to tie it on to an E&M like you do the other codes, because it's without direct patient contact. It just has to be related to an E&M service. So there's a little fine points within those codes that you'll want to make sure you're following. But yeah, that one doesn't have to be tied to an E&M. All right. So, and just breaking down your prolonged service codes, I try to do this when I talk about coding is to try to show the similarities or try to show the separation from a coding aspect when you're trying to break it down about how do I know where I'm going. So I try to kind of subcategorize and show the different ones. So when we look at prolonged services, they're done by time, by direct or indirect, and then by patient setting. So those are the factors that you're looking for to lead you to which prolonged services codes you want to use. And then of course, some codes are once 30 minutes of prolonged done. The new one is 15 minutes. They also do have some of those, the clinical staff ones are once 45 minutes have been reached. So once again, make sure that you become familiar with the code subsets there, and that you're choosing the right time elements that go with each, so that you're making sure you're meeting those thresholds to be able to report the services and get paid. All right, now here's a slide on the 99417 and the G2212. Now, if you look, I put what the descriptions say for these codes. And if you compare them and go back and forth and back and forth and back and forth, they're exactly the same. And so usually when CMS comes up with a G code, it's either because there's not a current CPT code for something that they're trying to carve out and make sure that in this certain circumstance, we'll pay for something, but we don't like the big code that CPT made. We don't like all of that that's in there. So we're taking a piece out of there and we're going to make a G code for that, and we'll pay you when it's that. And that's why they make the G codes, is because you're saying to Medicare, I'm meeting that exact criteria, right? But here with the 99417, CMS doesn't have a problem with the code description. They have a problem with how the AMA is interpreting their own code to match in with the times on the 99205 and 99215. So it's not about the description. It's about how the AMA says you should be using the code. Okay. And so let me get a little further into that. So once again, I made a little chart here to look at. So you see your 99205 is for 60 to 74 minutes, right? That's the range. The CPT add-on time is 75 to 89 minutes for the 99417, where CMS's add-on time for the 99417 is 89 to 103. So there's a big differential in time between when CPT and when CMS says you should be able to add on a prolonged service code. With the 99215, that's 40 to 54 minutes. Now, the AMA says you should be able to use the add-on code for prolonged service at 55 to 69 minutes, where CMS says, no, not until 69 to 93. So this is where the rub is. So CPT starts counting their 15 minutes to be able to do prolonged service from the beginning of the level 5 code, and CMS starts counting it at the end of the code range. So if you look here again, so 99205 starts at 60 minutes, it's 60 to 74. So if you add 15 minutes to 60, you get 75. That's where CPT says you can use the 99417. Well, CMS took a look at this and look at the range. The range ends at 74 minutes. So CMS said, so you're telling me if they go 1 minute over the range, you're going to give them the add-on code? No, we don't like that. We want to go to the end of the range at the 74 minutes and add the 15 onto that. So is everybody clear with, because this is the big deal here, is with the counting. Is everybody clear on what I'm explaining that as? If you could just give me a thumbs up or a happy face or a yes or something to let me know that you're understanding this. So I also put in here CMS final rule statements. So in the Federal Register, when the final rule came out, CMS tried to further explain why they were doing it. So they said, we reviewed the policy that we finalized last year. Thanks, lady. And we believe that allowing reporting of 99417 after the minimum time is exceeded by at least 15 minutes. Great, everybody's got it. Yes, thank you. Okay. And then they say the terms total time and usual service continue to be unclear. So CMS is kind of saying, in some of the places CPT says you get the halfway mark, and some of it, and for the 99417, they're saying it had to be the full 15. So we think that the way that AMA has it written out is just kind of not clear. And we continue to believe that 99417 as written is unclear as to allow the reporting of the code when the minimum required time is exceeded by at least 15. So CMS is saying that's not what it said, in the actual code descriptor and guideline. So CMS says, to resolve the lack of clarity, we're finalizing our proposal regarding that time may be counted, and to resolve the inconsistency. So now we are making our G code, which was G2212. And we want Medicare recipients, people that are billing for Medicare beneficiaries, to use that instead of 99417 because of that unclarity, because of that, because of that not being clear enough. So we believe the creation of this HCPCS code will serve to resolve the potential differences between Medicare and other interpretations of CPT rules. And all the places where it's bolded on this slide are places where CMS bolded it. I didn't bold any of this. So they're trying to say that, there was a lack of clarity, and, they want to make sure that it's being done to, being billed properly, not being overpaid. So that's why they made the G code. So now then I made some slides on, here is the AMAs. And if you look in your CPT book, right, the AMA has these tables in there for you. So it gives you the prolonged services, the 99205, and it will tell you if you have 90 minutes. You go and find it on the chart, you go 90 minutes, and then you go over and see it's 99205 and 99417 with 2 units. But that doesn't address the CMS issue, because remember, from CPT standpoint, CPT is made by the AMA. So the AMA is giving what their guidelines are. They don't take into account payor perspective. This is their rule. So in the CPT book, you only have the CPT tables. So I made another slide here that has the CMS rule on it. And so I made a CMS table for 99205. So now it's 89 to 103 minutes. And now that 90 minutes, instead of having 2 units of the G2212, you would only have 1. Because remember, they set off that 15-minute difference, right? And then I did also the same thing for the 99215, where we have the 99215 from the CPT book. And then we also have the CMS one that I made to counter, to be its counterpart. So you can use them in that same way. And that is where the little present that I was talking about is that I have for y'all. And when I'm done with the slides here, I'll show you what it is, and then I'll show you how to get it. So just another example here. If, let's say, we have a whole note, and the whole note is wonderful, and the whole note has everything in it that we need to have in it. And at the end of it, I spent a total of 90 minutes with the patient to examine and discuss all above documented issues. So I just wanted to make this kind of like a throw out thing, instead of making a whole entire note with a whole bunch of garbage in it. Let's say, because when I do this, there's always somebody that's got to say, well, it didn't say that. So we're going to assume everything is perfect in the note. We know that there was no minor procedure done, or if there was, it's not counted in here. So I'm saying we're counting 90 minutes just to make this a good example. So I have a couple different scenarios for how we would code it out. So what if the patient, let's take it the non-Medicare patient first. So if this is a non-Medicare patient with 90 minutes of a visit done, including everything pre, intra, post, it's all 90 minutes. We would be sitting at 99215 with 99417 and 3 units because of going through. And now again, with the 99215, the 99215 is 40 to 54 minutes according to the CPT book. That's our time range for it. Now, what if it was a new patient though? If it was a new patient, we'd back down one of the units of our prolonged service, because for new patients, now the CPT book says that's for 60 to 74 minutes. So depending on whether they're new or established is going to depend on how many units of prolonged service we get, right? Then we're going to take a look back at, now, what if this was a Medicare patient? Okay, so now we're going to pull our G2212 in. So if it was a Medicare patient and it was a new patient or an established patient, it would be 99215 and G2212 times 2 units. So notice here that even though in the first two answers here, they're both established patients. So they're both 99215, but the prolonged service units are different because of how they count them, right? And then if it's a new patient that's Medicare, then we would have 99205 and G2212, which is 1 unit. Again, stepping down from if it was a non-Medicare patient because of how they count it. So I was just trying to put one example where we could use varying different things, new, established, Medicare, and non-Medicare, where you could completely see how it changes over and over. So I hope that's helpful as you're looking at it. And if not, again, this will be both in LinkedIn and the YouTube channel for the company is I think one of our videos is up now, so we're getting that running. So when the YouTube channel is up, you'll be able to go to there too and see all the different videos that have been done, and you can go back and rewatch it as many times as you'd like to get it down, or shoot me an email and I'm happy to answer questions on things. I know just that some of y'all that are on here are people that are either colleagues or former clients or things like that of mine. So that I'm pretty good at getting back and answering questions on things. So if you have questions on stuff, I'm happy to help. But I hope that helps. And this is just, of course, I like to always put resources from where I went. And that big, long one, this one is where you can find that final rule where CMS put all of that language in there about why they were making the G code. All right. So the next thing I wanted to show you was this. This is, in fact, I'll do it all alone on the screen. This is that chart that I was talking about. So what I did was I made a prolonged services chart, AMA versus, and I put versus, but it's not like they're battling each other. It's just comparing the two. So you will have the prolonged services with 99205, and then I put AMA CPT, and then right below it, the prolonged services for 99205 for Medicare. And then on the second page has the 99215 AMA, CPT, and Medicare. So it just has that broken out. It's a nice, or you could even print it, two-sided to where it would just be one page. You could kind of have it sitting out for reference if you would like. So that is something that I am making available, at no charge, once I created it. Now, if you're interested in getting one, having one sent to you, what I would ask you to do is go to the website, the chcs.consulting website, and subscribe for my mailing list. Now, I don't send out a bunch of junk. I'm not going to send you 80 things a day. I just am trying to, keep track of people as I'm starting to get viewers to the broadcast and then onto the YouTube channel and things like that. And, as different things come out, I want to make sure that people that have signed up for the mailing list will get notices of different things. And I plan on starting a newsletter that will come out and show different things regulatory wise and coding wise and updates and, are you sure you're washing this and stuff like that. You can look for things in a lot of different places. So it's important, I think, to look in a place where you're trusting where the information is coming from. There's a lot of blogs and sites and things like that. And sometimes you just don't know where the information was received. So as you can see from the presentation I just did today, I listed the resources and this is, for a broadcast. So anytime I put things out there, I always like to put the resources so that people can go ahead and do their own research on it and like pull down the whole document or the whole whatever and read the entire thing for themselves and things like that, so that they understand maybe my perspective is a little different than the perspective that you may get when you read it. So that's why I always like to give those things, and to know that I really try to keep my opinion out of things when I'm doing those. I like to put in what the source is and what the source says. How you interpret it, if there's, sometimes they're black and white, as we know, and sometimes they're not. So that's why I like to do this. So if you would like to get that prolonged service chart thing that I made, if you want to just go to the website, and in a minute, I'll put a little banner up where you can see that again. If you just go to the website and put and you see all I want is name, last name, and email. I'm not asking for addresses to start mailing you stuff and all that kind of stuff, or phone numbers. I'm not going to call you up. So if you would like that information, please go to the website and join my mailing list, and we'll send a copy out to you. Send you a little PDF of it so you can print it off as many times as you need to. And share it with others in the office, and use it, and hopefully it'll help you. So, all right. So, oh, thank you, Lady and Mary, for saying that I'm giving you good information. I appreciate that. I really do, try to get that kind of stuff in here. So let me so here, if you'd like a copy of that prolonged services chart at no charge, please just go to chcs.consulting and join our mailing list. And just one little comment about the website name, because I do have a lot of people that say that that's not it should be a .com or that's not right. It doesn't, the .coms and things like that for the CHCS part were already taken by other people. So I had to get they call them a vanity one, but it's not really, vanity. It was because the .coms were already taken, and .orgs and all that. So it is actually chcs.consulting. So if you just go to the website, like I showed you, just getting onto the website, after you're on it for about 20 seconds, that little thing will pop up that says to subscribe to the newsletter. And, so if you do that and I get the notice, I will send you one. All right. So I also said I wanted to take questions when I put this out on LinkedIn Live. I asked people to send me some questions if they had any on prolonged services, so I could answer them on the broadcast. So I got a couple questions, and then after I answer these, I'll see if anybody else has any questions. And I'm happy to try to answer them for you. But one of the questions was, what are great examples to use regarding the criteria that are needed for utilizing prolonged service codes? And I wasn't quite sure the entire meaning behind Sally's question, but I think at the beginning of the broadcast, I made some different examples of what I think are good uses for prolonged services, like with HEMONC and PD cards and things like that. But I think the important thing is to remember that checklist of things, that it's all services pre, during, and post, as long as they're not separately billable as something else that your physician or other provider is doing. So the important thing is to get them used to documenting that way, or keep on track that way. Because in the past, we used to tell them, anything you do that's not face-to-face with the patient isn't counting. So, they would still do the things they needed to do to prepare for the patients, but they just, weren't documenting it because they weren't getting compensated for it, or so they thought. So now that it is, that's always one of the hard things that I have found when working in a practice is, well, they never got paid for it before, so they don't document for it. And then all of a sudden it's getting paid for, and half the time they keep forgetting to document for it. So just make sure you're capturing all of those things that they are doing, looking at the records, looking at talking to other providers, looking at the notes, looking at the stuff from the hospitals, all of those things, and then coordinating care. If you're talking to another office, and when I say you, I mean that physician or other provider, remember, because if it's clinical staff that's doing the phone calling about setting up appointments and that kind of, that time we're not counting. We're counting the physician or other providers' time in doing these things. So if they're speaking to another physician about something, some procedure that physician's going to do, and saying, these are the kind of things I'm looking for, or, what I think may be wrong with the patient, that kind of stuff. So just make sure they get better at documenting that. So maybe in your EMR templates, you'll kind of want to play around with them a little bit. I've worked with a couple practices on adding some things in their EMR where the little boxes or prompts will come up to remind the physician, oh yeah, I'm supposed to be documenting this stuff now because it's going to make a difference. And these are all the things I'm adding up at the end of the day to see how much I'm going to get out of this from a coding standpoint. So I think just little prompts like that will be a helpful thing. And then another question I got was from Andre, who asked, how do I know whether to use the G code or the 99417 for a patient's claim? That can be a little bit of a harder area, because the straight answer would be, of course, use the G code for Medicare, the 99417 for all non-Medicare. But there may be other payors other than Medicare that also, once Medicare made this statement about the G2212, about the 99417, saying, I don't think it should be counted, from the beginning of the range. It needs to be counted from the end of the range. So you may find other commercial payors who follow CMS guidelines for things like NCCI edits and stuff like that, that they also follow Medicare when it comes to this prolonged service issue. So you may have other commercial payors who want the G2212 also, instead of the 99417. And the reasoning they will give will be they're following Medicare's guideline. So, that will take a little bit more tracking, on the practice from how claims are coming back in. I mean, you'll know right away if you send a claim to a commercial payor with the 99417 on it and they deny it and send it back, that they're looking for the G2212 because of that time reason. Because if you noticed, the units on the add-on code, when it went from 99417 to the G2212, always went down. So from a payor standpoint, they're going to be paying less for that claim than they would if you were using the 99417. So you're probably going to have to keep some stats and track that in the practice to see which commercial payors want the G2212. But if it's a Medicare patient and you're billing Medicare, you'll want to use the G2212 for that. You see, I do have another comment over here, so let me see. Lady is saying recently United Healthcare removed the 99417 from their policy and implemented the G2212. So there you go. And United Healthcare, United Health Group, that's a pretty big payer for a lot of people. So make sure you're paying attention to those policies. And thank you very much, lady, for putting that comment out there. I appreciate it. So does. Let me go back to my banners. That one. All right. Are there any more questions or comments from people about the 99417 or the G2212 that I could answer for you? All right. Let me then. I'm going to put in the comments. No, I can't. That's right. So I'm going to one more time just put that banner up again about the prolonged service chart. I hope you all find that helpful. We'll find that helpful. And as I don't see any more comments. Oh, no, one more came in. Oh, thank you, Rose. Thank you. I appreciate that very much. All right. Well, everybody have a good Halloween, which is coming up. I probably will do my next broadcast in probably 2 weeks. And I'm going to try to see if I can have my attorney friend do a session with us. He's a healthcare attorney, and maybe kind of talk about what he does and different things that his practice does for physicians' practices and assisting them with payor issues and different kinds of issues and compliance plans and all kind of stuff like that. So just be watching on LinkedIn for me to, have that post that's coming up to show you when the next session is. And Sandra, thank you for that comment. I really appreciate it. And so everybody have a wonderful rest of your Baby Friday and enjoy the upcoming weekend.